This was kind of interesting. The patient had number 30 extracted 8 months ago in a different state. They had recently moved, and this is a new patient to our doctor's office. The extraction site was grafted. However, our MISH attendee could not find out what type of bone. So that's a second red flag that I have, and we'll talk about that in a second. The chief complaint of the patient was they want a missing replacement of the missing tooth. The doctor's concern is the bone density in the area of question. So why did I say this is a concern? Well, number one, whenever you get a patient that you can't get the information on, especially bone graft material, there are so many different bone substitutes out there now, and it can really impact on how you're going to treat this case. Was it a autograft? Was it an allograft? If it was an allograft, was it demineralized or mineralized bone? Was it a xenograft? Or was it an alloplast? So you could be looking at a bone that would be very favorable, or a bone type that would be very unfavorable. And again, we'll go through that as we go through the case. So the first thing I'd like to do is look at the 3D evaluation of the CBCT scan. So you can see here on the left, there's a lot of width left here, and it doesn't look like we've lost too much crestal height. So the first thing that we want to do is go over all the treatment options for this patient. So you always want to give the patient all the possible treatment options available. So if we look at what are they? Well, no treatment, but use that as a positive and a benefit to explain this to the patient and educate them. Yes, Mrs. Smith, we don't have to replace this, but you're still going to have trouble chewing in that area. You're going to get food impaction. The adjacent teeth are going to tilt. The tooth above it is going to super erupt, which is going to be a problem. Also, you will have bone loss if you wait too long, then someday you might not be able to have an implant. Second option is a fixed partial denture. What are the disadvantages of that? You have to prepare the adjacent teeth, possible endodontic therapy, decay. We know that with a fixed partial denture, number one leading cause of failure is decay. Why is that? Because it's very hard to clean. So there's hygiene issues with that. And then we go to the third, implant, disadvantages. People always talk about the treatment time, but use that to explain to the patient how the whole process works and how the treatment plan is not that significant. And the cost, is it more expensive than a fixed partial denture and any of the other treatments? This is where you can get into kind of explaining some of the costs involved in it so that patient understands that. So ideally, you should be able to explain all those to the patient and hopefully give those in writing to the patient. So now that leads us to a question. So if this patient selects a fixed partial denture, what is the probability that endodontic therapy will be needed on either one of the abutments, number 29 or 31? A is 3%, B is 7%, C is 14%, D is 25%, and E is around 35%. And this is based on literature. And we see actually the C is the correct answer. So if we look at this, why did I even put this in there? Well, the reason I put this in there, the literature is about 14%. Some studies are a little bit higher, 15, 16, and some are a little bit lower, but probably an average is about 14%. Why is that? Why is that important? Well, when you explain that fixed partial denture to the patient, yeah, they want a bridge, they want it done yesterday, but Mrs. Smith, do you realize when I prep this tooth, you have about a 14% chance of needing an endo on this tooth, which is going to be more expensive. It's going to decrease the longevity of the bridge, predispose the adjacent teeth to problems. So this is something that you can use as a positive and explain that to your patients. Second question, with respect to the patient's medical history, what test would be the most practical in evaluating the patient's diabetic control? Patient said that they're a diabetic. So even though they say they're controlled, we have a duty to evaluate that patient. Is it blood glucose, hemoglobin A1C, glucose tolerance test, or a fasting plasma glucose? B is the correct answer. So the majority of the people pick B, which is great. Now, why is that significant? Well, the reason that the hemoglobin A1C is a huge benefit to us is it shows us how well controlled that patient is over the last 3 months. What it does is it measures the amount of hemoglobin bound to that red blood cell. The red blood cell lives for about 3 months. So it tells us how well controlled the patient is. Everyone's used to getting a blood glucose, but that just gives us a snapshot at that exact time what their blood glucose is, and it really can give us some false positive and false negatives. Third question, to minimize complications, what I talked about, what should the patient's hemoglobin A1C be? Less than 7%, less than 8%, less than 9%, or less than 10%? So most studies out there show that less than 7%, the patient's going to have less problems with wound healing, incision line opening, bone healing, and possible early implant failure. So we like our patients less than 7. So that gives us, what do we do when the patient's over 8, 9, 10? We refer them back to their physician. We explain to the physician that the patient needs to be better controlled, because what we are doing is we want to do this once and we do not want complications. So let's get back to evaluating this patient. The next thing we're going to do is evaluate the CBCT. And I like to look at the 3D images and evaluate the interocclusal space. A lot of times on these single teeth, what happens is you get super eruption of the adjacent teeth. We know we need about 8 millimeters of interocclusal space. That's from the opposing occlusion to the crestal bone on the adjacent ridge. We need about 5 millimeters for a screw retained prosthesis. So you want to evaluate that. If the patient is compromised, such as you have a tilting cusp here or a rotated cusp, what you want to do is adjust that opposing cusp, and always tell the patient that at the beginning of treatment, so that if you do have to do a significant adjustment post-operatively, that the patient doesn't think that you're doing that just because your bridge does not fit. So evaluate the interocclusal space. The next thing I like to do is evaluate the buccal plate. What we're looking at is that buccal plate is there any issues with it, such as, is it missing or is it real thin? We have learned over the years, now the buccal plate is very significant in longevity, maintaining the soft and the hard tissue drape around that area. So the next thing we want to do is look at the bone density. Now this was the doctor's concern. What he saw was where that extraction site was, the bone density wasn't real good. So what we're looking at is the Hounsfield units. We can do this on the software, and the red arrow is right in the center of where the extraction site was. And I gave you just a reading so you can see what the cortical bone is. It's 1278, which is really good D1 bone. We're looking at about D3 bone. And then we place an implant into that area, and we can take an average Hounsfield unit in that area, which is about 572. So the bone is compromised, but it's not so compromised that we can't do the case. We would just have to modify our protocol. Mainly the surgical protocol, we would under prep this or osteodensify it to keep more bone at the implant interface. The next thing we're going to do is evaluate the height and the width. So we measure it. All CBCT scans are 1:1, meaning there's really no magnification. So we have 10.8 millimeters in width and 16.4 millimeters in height. So we have a lot of bone here. This is what we call division A bone. So let's go to another question. when we're treatment planning this for the implant, how far, minimum distance, should the implant be from the mandibular canal or the mental foramen? Also, what we call the safety zone. The answer is D. Very good. Now, if we look at studies, almost all the literature out there states a minimum of 2 millimeters. Why do you have to be 2 millimeters? Well, number one, remember, most burrs that we use, surgical drills, have a Y dimension, which means if you're drilling 14 millimeters, you're actually drilling more than 14 because the drill is longer than the length of that implant. So you always have to drill deeper, and that's just the engineering design of the actual drill. Secondly, you can get a thermal necrosis. You can actually cause a hematoma, et cetera, that will really complicate and possibly end up with a neurosensory impairment. So staying 2 millimeters away has been shown to be an adequate space to prevent any complications. Next question. What is the maximum length implant you should use in this area? We have about 16 millimeters of bone height. So it's 9, 10, 11, 13, or 16 millimeters. Very good. Okay, so if we look at that, here's the easiest way. Take the available bone length or height, 16.4 millimeters, subtract the safety zone, we have 14 millimeters. Look at the available implants. I showed you the Hahn system there. So they have a 13 millimeter and a 16. So the ideal length would be 13 millimeters. You never want to go more than that safety zone number that you have. So when we go ahead and place this, when we place the implant into the CBCT, we know we're going to have a 13 millimeter implant. We know that the width is about 10.8 millimeters. So for a molar, we're usually using a 5 or a 6 millimeter implant. In this particular system, they have a 5 millimeter implant, which is good. So we will be placing a 5 by 13 millimeter implant. When you place the implants for this surgical guide, or if you're in surgery and actually placing this, what I want you to do is always look at the adjacent tooth and look at the long axis of that tooth. And you want to parallel it. So the implant should always be parallel to the long axis of the adjacent tooth. And I will show you as we go further, when the molar there, when you have a distal inclination, the second molar, that changes a little bit, and I'll show you that later in the presentation. The next thing is we want to look at our trajectory. Ideally, we want that stamp cusp or that plunging cusp over the central fossa, over the long axis of our implant. So what are we going to do? We're going to put our trajectory of our implant right into that lingual cusp of the maxillary first molar, just like that. Okay, and then we're going to verify the length to make sure our safety zone is good. So next question, after implant placement, ideally, what is the minimum amount of buccal bone that should be present according to the latest literature? 0.5 millimeters, 1 millimeter, 1.5, 1.75, or 2 millimeters. So this has changed, and the reason why I put this in there, we always taught in the past, first 25 years ago, we taught 1 millimeter. Then it was 1.5 millimeters. Now the latest literature states that you need about 2 millimeters of facial bone. So if you have to decrease or change the positioning, you can always take it from the lingual. The lingual only needs 1 millimeter because usually it's a stronger cortical plate. Buccal bone is always thinner than the lingual cortical plate. And what the studies have shown is that with that 2 millimeters of bone, you have less resistance to tissue recession and bone loss around that implant. So this is the same with an immediate implant. We want 2 millimeters of bone on that facial aspect to protect that implant. And that's more the new literature that has come out. So we verify the placement. We check our buccal and our lingual thickness. Again, we want greater than 2 millimeters and greater than 1 millimeter on the lingual. Going forward, now we're going to look at the buccal lingual positioning. The easiest way to determine where it should be in the posterior is look at the central fossa. It's very easy. Look at central fossa, the second bi, second molar, and then all that you do is place that center of that implant right in the middle of that area. And now our stamp cusp or our plunging cusp from above will be right in that central fossa over our long axis of the implant. So as I said, there are sometimes issues with the second molar when you're replacing the first molar with the mesial distal positioning. So when you have a distal inclined second molar like this one, you don't go parallel just to the second bi. You bisect the angle or the long axes of the second bi and the second molar. So you can see that is more of a proper position. And that is basically the only tooth that in the mouth that has that issue, mainly because of the very common distal inclination of that second molar. So of the following templates, another question, which is the most accurate surgical template? A mucosal supported template, a bone supported template, a tooth supported template, or a stackable guide? So when you look at accuracy, what I mean is using this template, which one of these would put you in the most accurate position? It's a tooth supported template. So why is that? Well, if we look at a tooth supported template right here on the right, why that is so accurate is we use teeth to hold that template in place. If you see this template, this is 3DX's design, and it has open windows in it. And what those open windows are for you to make sure and make sure that that is completely seated. If it is completely seated, definitely a tooth supported template is the most accurate. If we look at our list, the least accurate is a mucosal supported template because this is a template that rests on the tissue. Tissue is very variable, it gives, and it fluctuates from when that CBCT was taken. So the bottom line on this is a tooth supported template. If you can ever use one, that is the most accurate. A bone supported is the second most accurate, and certainly in the mucosa is the least accurate, and that is pretty conclusive on most of the studies out there. So the next thing we're going to do is we're going to fabricate a template, and it's very easy. The software already does it. If you use 3DX as treatment planning, they basically design it for you and it's ready to go. So this is the design of it. I did add one thing that I want to make people aware of. Sometimes, especially early on your learning curve, some of these posterior implant surgeries are very difficult because of the patient limited access. So the patient basically can't open wide. When you use these guides or the templates and the surgical drills that go along with them, they are usually longer than standard surgical drills. Therefore, it's very difficult sometimes to have access to put the implant drill back that far. So I would like everyone to get used to what is called a buccal or lingual access. And again, 3DX make them this way. You have to ask for it. But what they do is they have the buccal or the lingual open of the tube. The tube, which prevents any misalignment of the drill, is about 5 millimeters in height. But what they do is they just take out the buccal or the lingual, so you actually slide the drill in from a buccal or a lingual access. It's a neat little trick, and it saves you 5 millimeters, which is about the size of the extension that those guided surgery drills have versus the regular standard surgical drills. So again, you have to ask for that, but certainly a first and second molar would be a great time to use that buccal or lingual access on the surgical template.